Thank you.
Thanks for being here.
Sure, it's a pleasure to be here. Thank you for inviting me. Jim, do you want to introduce yourself?
Oh, I'm happy to. I'm sure I'm just a few minutes at the end, but my name's Jim Stempel. I am a scleroderma patient. I was diagnosed in 2010. My main affectations are internal, not external. The lungs were damaged the most. And my friend and physician, Dr. Tomic, was my lead transplant pulmonologist, and I had a transplant in 2018. Just my left lung, not both, and couldn't be happier about it. And I'll spend a few minutes at the end just walking through my story and fielding any questions.
Thank you. I'm Rade Tomic. I'm the pulmonologist, lung transplant medical director now at University of Chicago. So it's a pleasure to be here. Thank you for inviting us. Focus of my presentation will be about pulmonary hypertension as indication for the lung transplant, and we'll talk about timing of the lung transplant in general for any condition, and a little bit about the surgery itself and outcomes. Anybody here has pulmonary hypertension, if I may ask? I see. Okay. Sure. So I'll just kind of in a few words, what is pulmonary hypertension? It's some patient will develop pulmonary hypertension. I will explain in the following slides how that happens in the patient with scleroderma. But basically, it's increased pressure between the heart and the blood vessels in the lungs. So the heart is working under higher pressure. And my colleague who is coming, he'll talk more about interstitial lung disease in scleroderma, and I will focus on the pulmonary hypertension as indication for the lung transplant. So I don't have any disclosures. So scleroderma can affect the lungs in two different ways. One and most frequent one is the interstitial lung disease, so developing of the scarring in the lungs. Scarring can have two types. One is the NSIP, the other one is UIP. NSIP is more frequent, which means non-specific interstitial pneumonia, and has a little bit slowly occurs. Patients who have UIP pattern, which stands for usual interstitial pneumonia, they have a little bit more aggressive disease. Now going back to the pulmonary hypertension, again, there is two types how the scleroderma will cause pulmonary hypertension in the lungs. One is just affecting the blood vessels that are going through the lungs without affecting lungs itself, and that's the type 1 of the pulmonary hypertension. Type 3 of pulmonary hypertension in the patients who have interstitial lung disease and the scarring is progressing and causing a damage in the lungs. That will ultimately cause increased pressures on the heart and cause pulmonary hypertension, and that's the type 3 disease. There is type 5 of the 5 types of the pulmonary hypertension. So when we need to think about lung transplant for any patients who need lung transplantation, not just scleroderma, but any patient. So lung transplant is the last option. When all other therapeutic options are exhausted, then we think about lung transplant. The other way how we think about in the lung transplant community is that when anticipated survival for the patient will be less than 3 years after we see the patient, or when we see the patient, then we should think about lung transplantation. So sometimes it's hard, it's not easy actually to say if the patient is in the right place for considering lung transplant. Obviously, we don't want to transplant the patients who are too healthy and can wait because, as I said, this is the last resort. And however, we know when the patient is transplanted, when they are very sick, they actually have worse outcomes. So these are the couple of the important, again, thoughts that we have when we are seeing the patients with pulmonary hypertension, with scleroderma, or any other lung disease. If based on the best available data that we have, we anticipate that patient survival is less than 50% over the next 3 years, then we think transplant is indicated. And what is also very important is that patient does not have any other diseases which will limit their survival after the lung transplantation. And we'll find out that through the evaluation for the lung transplant. And, that's why all the patients have to go through the extensive battery of the test prior to the lung transplant. So, in other words, patients should be sick enough to require the lung transplantation, but also on the other side, should not have any other organ involvement which will limit their survival after the lung transplant. One very important thing is that, and I'll touch on that in the following slides, that it's always better that patient is referred a little bit earlier for the lung transplant, not when the patient is extremely ill in the ICU and so on. And I will explain later why is that important. So the process goes after we get referral. One of the people who are working on intake will contact the patient within the 2 days. Coordinators for the lung transplants, who are usually nurses, will contact the patient within 7 days of referral. And the next step is the seeing of the lung transplant pulmonologist, who will decide if we need to proceed with evaluation or we can wait a little bit longer. So one also kind of important thing to remember is referral for the lung transplant doesn't mean listing by itself. Many patients, about 50% of the patients who get referred for the lung transplant will proceed to the evaluation. About half of this who goes to the evaluation will get on the list. So when somebody is referred, there is a whole extensive process that is coming after that. So that's why it's important for the patients to be referred earlier. One of the things that we achieve through this process of evaluation is comprehensive education of the patient and the family. What is the lung transplant about? What they can expect, what are the outcomes, what are the commitments from the family regarding the support after the lung transplants, and etc. So it's always good that we can talk about that in relatively peaceful settings, not when somebody is on the ventilator in ICU and so on. The other important reason why patients should be referred early is there is a number of the potential barriers to the lung transplant that we can address in timely manner if the patient is referred enough early. Obesity is contraindication for the lung transplant. Now we have good medications that we can treat obesity and prepare patient better for the lung transplant. Similarly, if somebody is malnourished, we can work with dietitian to get patient ready for the lung transplant, because we know if somebody is obese or malnourished, they will have worse outcomes after the lung transplant. We also want to optimize and evaluate other medical problems. Because, for example, if somebody has coronary artery disease that requires intervention with a stent to open the blood vessels in the heart, they will need to be for 3 months on the blood thinning medication, and that will postpone the lung transplant. And again, if somebody is extremely ill in ICU, we don't have these 3 months. That's why that early referral is important. Also, we can work on the psychosocial support. We can inform the family. Family can make arrangement for that patient, because they will need to be there for the patients after the lung transplant. As I mentioned before, part of the evaluation is assessment of the other organs, making sure that there is no any other organ damage that will preclude potential lung transplantation. We want to rule out malignancy during the process of evaluation. So all patients who are going through the evaluation for the lung transplant, they have to be up to date with cancer screening. So for example, if somebody didn't ever have a colonoscopy, we'll need to arrange colonoscopy for the patient in that time to make sure that there is no any cancers or any kind of dangerous lesion in the bowels and so on. And we want to finish vaccination before the lung transplant because, there is a lot of talk about vaccination in the community and so on, but why is that important for the lung transplant? After the lung transplant, patients goes on medications which are used to prevent rejection, but what they do, they get their immune system down and they will not be able to fight infection. So we want to do that vaccination before to prepare them for the lung transplantation and potential problems after. So a little bit about pulmonary hypertension. When is the time to consider referral for the pulmonary hypertension? All the patients who have scleroderma have to be followed closely. And if they have pulmonary hypertension, they should be started on medication and followed how they are doing on medication. So they should be followed very closely. If they have pulmonary hypertension, if they don't respond on the medication over the 6 months treatment, that's indication for referral for the lung transplant. Similarly, if they're using one of these medications which are used for pulmonary hypertension, which is intravenous prostacyclin or subcutaneous remodulin, which are medications specifically used for pulmonary hypertension and for advanced pulmonary hypertension, they should be referred for the lung transplant. When we want to list the patient with pulmonary hypertension, if the oxygen needs are increasing, if they are not responding on the therapy for pulmonary hypertension, and if they are starting to have issues with the kidneys caused by pulmonary hypertension and interaction between the heart and the kidneys. So I hope you will be not kind of stressed with this slide. The type of the lung transplant that we do for pulmonary hypertension, one type is the bilateral lungs. This is very beautifully looking lungs on your left. And in the very few patients with pulmonary hypertension, we'll need to do transplant of the lungs and the heart. But usually, lung transplantation, particularly in scleroderma patients for pulmonary hypertension, will include just both lungs, but always both lungs. When the patient is going through the operation, patient will be placed on what we call ECMO. This is abbreviation for extracorporeal membranous oxygenation, which means basically artificial lung. So the patient is started when they go for surgery on that artificial lung. They will be also on the ventilator. When the surgery is done, that artificial lung will be disconnected, but patient will be still on the ventilator, usually for 2 or 3 days after the surgery, and then extubated or disconnected from the ventilator. And in one of the last slides, or probably last one, regarding the outcomes, the same outcomes for pulmonary hypertension caused by scleroderma are the same as the outcomes for any other indication for the lung transplant. Sometimes immediately after the surgery, they will have a little bit rougher course. They will have what we call this primary graft dysfunction, which means that lungs are not working for one or the other reason immediately after. But over the time, lungs will get working well and normal and stabilized. And long-term outcomes for a lot of patients with scleroderma, actually, if they have pulmonary hypertension, better than the long-term outcomes from some other diseases such as idiopathic pulmonary fibrosis, and etc. So this will be briefly about lung transplant. This is from my previous institution, how that looks like in the OR. And I think on the end of our panel will probably answer on the question, but certainly if there is any questions now, I'll be more than happy to answer. Thank you. Yes.
Yes. You mentioned there are 5 types of hypertension. When you're at the assessing the risk, you actually diagnose what type of hypertension so they can give that information to the primary doctor? Or?
Yes, when we are kind of evaluating patient for the lung transplant, we'll probably know if that's in the scleroderma patient, that's just these 2 type 1 or 3, type 1 or type 3. And we'll know what type of pulmonary hypertension we are dealing with, and we'll pass that message to the primary pulmonologist.
Follow-up question. So it's never 2, 4, or 5?
No. Yeah.
For this type of scleroderma damage to the heart?
Yeah. Scleroderma damage to the lungs caused by interstitial lung disease will be that type 3. And if without any damage to the lungs, scleroderma can cause problem with the blood vessels in the lungs, and that will be the type 1.
Okay, thank you.
Sure. Yeah.
I'm just curious what the wait lists are like.
So,
Like compared to like other orders.
yeah. So it's actually different from institution to institution, and it depends also how sick patient is. But it's reasonable expectation if somebody has pulmonary hypertension due to scleroderma to get transplant within the 3 months from going on the list. But it takes about 2 to 3 months to finish all of this process of evaluation and so on.
I had a question as well. You had mentioned toward the end of your presentation that it's most typical to do bilateral lung transplantation. At the same time, you had mentioned when you introduced yourself that you had just the left side done. Is that typically done just due to the quality of the right lung or the other lung? Or
I think it's because I didn't have pulmonary hypertension.
Correct. That's a correct answer. This is just for pulmonary hypertension that is needed bilateral lungs. For the patients who have interstitial lung disease that Dr. Tsui will talk about, they can have 1 lung. So I can introduce Dr. Tsui, who is also one of the lung transplant physicians from University of Chicago.
Hi, everyone. This is loud. Great. Okay, great. Should I sit here, stand there? Do you have a preference? Whatever we do. Oh, sure. Okay, great. Yeah. So, hi, everyone. Name's Dr. Kevin Tsui. I'm one of the transplant pulmonologists over at the University of Chicago, and today I'll be talking about scleroderma and some of the unique nuances when it comes to lung transplantation. So just a little bit of background. I know that Dr. Tomic had already gone over some of these materials, but essentially is that any patients who have end-stage lung disease where they've exhausted medical therapy, and especially if they have an expectation that their long-term survival is potentially less than 2 years. In some of their cases, for like patients who have COPD, there may not be necessarily a survival benefit, but really if they're just feel like they're just breathless all the time, they're suffering, they've gone over all their therapies and whatnot, and they're wanting to achieve a better quality of life, that is also an indication. And for the most part, the eligibility is on our side adults, although we do some older pediatric cases, and that they have good rehab potential and that they can take all their medications. So this graph here is just it's a lot of colors, but the point of this slide is to say is that lung transplantation as an indication for end-stage lung disease has been progressively increasing, especially since the 90s, especially when we had changes in our immunosuppression strategies that help substantially improve the survival of our patients. And over time, the indications for transplantation have changed. Previously, a lot of it was predominantly from the COPD category, but now because of the indications and the prioritizations, a lot of patients who have interstitial lung disease, or especially with scleroderma patients, that indication has been increasing over time. When we look at long-term survival, the red line here, that's for single transplants, and for the blue line there, that's for bilateral or double transplants. The survival, now again, this is a median survival. This is not to say that, from day 0 to whatever, you only have 5 years to live, 7 years to live. But when you look statistically at all comers and all ages, for the patients who have a single, they're 50% survival, meaning that half are still alive, but half have passed after a certain period of time. That on average is somewhere, a median number is around 5 years. For patients who have a double, that's somewhere in the ballpark of around 7-8 years. But again, I've seen some patients live 20 years out and do very well. I've seen some patients who have, for reasons that oftentimes we can't control, have issues and only make it to 2 or 3 years. And even if you optimize everything.
Can I just say something because
I
of
can
that?
see why you'd say
Yeah,
that.
for the patients who survive 5 years, 80% of them survives 10 years.
I
Yes.
didn't need, you taught me well before that I shouldn't worry about that.
Yeah.
I just said that
Yeah.
because
So a lot of this is aggregate data. That's the point that I'm trying to emphasize here. And if not surprisingly, the ones who do well are the ones that usually typically would continue to do well. When we look at the causes of mortality, death after assuming patients make it to 1 year, which survival is 95%, which is very good. The leading cause of issues is chronic rejection, and that's for various different reasons. But essentially, is they'll develop oxygen dependence, they'll have lower lung function, and they'll have difficulty breathing. The second leading cause of death is infections, which is highly related to the fact that they're on medications that suppress their immune system and just make them more susceptible. And then the third category actually is cancers. And a big part of that is because you're on medications that suppress their immune system. And one of the primary functions of the immune system is to guard against developing cancers. So there is an increased propensity for that. So that's why oftentimes we have all the patients see a lot of dermatologists for skin cancers, a lot of sunblock, a lot of hats, long sleeves, and whatnot. And also that's why we also recommend that patients continue their regular cancer screenings. So the surgery itself, and again, I apologize if a lot of this is covered by Dr. Tomic, but essentially is if you do a single transplant, it's making an incision between the ribs, and we spread those spaces and take the lung out and then place a new one in, all, of course, while the patient has the breathing tube in, they're intubated under general anesthesia. If you do a bilateral or a double, you make a similar incision between the ribs, cut through the sternum, what we call sternotomy, and go all the way to the other side and kind of open the chest, kind of like a car hood, so to speak. And then we take one lung out at a time. Depending on the surgeon preference or depending on the patient's medical stability during the surgery, they may need to go on a heart-lung bypass machine during the case, and typically can be taken off of it afterwards. Although if there are issues, they may need ECMO afterwards. And this is just the illustration where basically we instead, because a fair question may ask is, oh, well, how do we do it and why do we do it? So essentially here you can see that if this is the main airways and the right and the left main bronchi, we make an incision very close to where the branches occurs. And that's because we found that if you make it any higher and you just do it as one on what we call en bloc, one large piece, there's a higher risk where the sutures where it connects to, it has a higher risk of failure. So we found that actually by preserving the native airways as much as possible and the donor airways on the shorter side, that's why we call it a bilateral sequential transplant, and that's the reason why. And then we just reattach it, and then we go from there. So evaluation, I know that Dr. Tomic went over a lot of these, but it's a lot of elements here. But the main point is that what we're looking for ideally are patients who have single end-stage organ dysfunction, and that they don't have any other major medical issues. Now, granted, if you have somebody who has uncontrolled high blood pressure or very poorly controlled diabetes, as long as you can optimize those things and get them into an ideal range, then that's what we're looking for. And you meet a lot of other people along the way, pharmacists, dietitians, social workers, to not make sure that that from the medical side everything's good, but holistically that they can take their medications, that somebody can be there to help take care of them and watch them and bring them to the emergency room in case of emergencies. For the usual post-op care, usually the patients after they come there to the OR, usually will keep them intubated for about 48 hours, and part of that is just so that we can give the lungs a chance to just recover, make sure you don't have the PGD issues, and then from there we ideally try to get them out, and then afterwards they may have some central lines which we eventually take out, right, and then eventually get them to the floor, and they'll just have some chest tubes that are there to drain any blood or fluids and whatnot. And after you can achieve all these things, the major priority is the patient up and ambulatory? Are they getting out of bed? Are they walking around? And that they can be functional at home. Now, certainly if some patients are very weak for whatever reason, they may need discharge to a acute rehab facility afterwards just to get stronger. In terms of complications, a various list of things can happen, but I think the ones that we always counsel patients on is just understanding that some of the more severe complications can be that for whatever reason, either pneumonia or weakness or what have you. If they have difficulties getting off the breathing machine, they may need a tracheostomy afterwards just to help rehab their strength in their lungs and usually it's not permanent, but they oftentimes have to go to a trach facility in order to help weaning with that, and sometimes if the kidneys run into issues, which I'll get into a little bit in relevance to scleroderma, they may need dialysis. Sometimes it's temporary, sometimes it's more long term, but generally speaking, the vast majority of these patients they do very well, and usually our typical postoperative stay is anywhere from 2 to 4 weeks, and then we follow patients outpatient. From there, usually when it comes to medications, we have patients on at least 3 different types of immunosuppressive medications, which they can have various side effects. That can include high blood pressure, diabetes, worsening kidney dysfunction, and also to increase risk of infection. So oftentimes we'll have to have patients on at least one antiviral, one antifungal, one antibiotic. So you can see how this is all adding up, right? So as a result, if you were never on any medications before, you may need 6 to 10 new medications after transplant. And, and I know this may sound like a lot, but this is just typically the typical experience for most of our transplant patients. There's a lot of clinic visits initially for the first month. It's once a week, then eventually every 2 weeks, and then once a month. And then after the 1 year, a lot of times we have patients followed either every 3 or 6 months, some annually, especially if they live out of state. And it's kind of become sort of a marriage, so to speak, where really the transplant patients are always interfacing with our team, just making sure like, hey, I have a new medication. Is this okay? Is there anything I need to be worried about? And just getting regular blood draws to make sure that their medication levels are at the therapeutic range. In terms of complications, one of the big ones really is just acute rejection and chronic rejection, which we're always concerned about. Usually acute rejection, if it does occur, it's within the first year, and we can certainly easily treat that, and we just intensify their immunosuppression. They may need increased dose of steroids temporarily, but we usually can treat that pretty well. Like I said before, chronic rejection is the leading cause of complications and death following after 1 year from transplant. And at that point, there are some more limited things, but this is why we emphasize that everyone is taking their medications appropriately and correctly, so that you're not giving your immune system chances and opportunities for recognizing the donor, so that you can minimize the risk of developing rejection. And in certain cases, if patients are necessary, retransplantation may be considered. So just a couple of unique considerations for at least for scleroderma patients, and there's a few myriad of things here, but the basic thing I want to just emphasize is that there isn't necessarily one puzzle piece to this all that's like an absolute contraindication. These are all things that we all consider for patients with scleroderma. And I know Dr. Tomic already mentioned this overall, but basically the survival with lung transplantation, and the only point of this graph is just to say that even though I'm not flipping back and forth, is that the outcomes exactly as Dr. Tomic had mentioned, they're comparable and they're the same compared to other patients who have pulmonary fibrosis. But I think there's a part of it which is there's also a little bit of careful patient selection, right? Because various things that are unique to some of our pulmonary hypertension patients, such as scleroderma, renal crisis, pulmonary hypertension, muscle weakness that can be associated with the disease, and especially esophageal issues, these can all have impacts in how we manage and consider these. I'm going to talk about right now. So it's not. I know Dr. Tomic mentioned this a little bit, but briefly saying that the referral guidelines is that generally speaking, especially for most of the community pulmonologists, we just say that whenever they have a diagnosis of ILD, they should just make the early referral. But as Dr. Tomic was saying, just because you have to make a referral doesn't mean that we're going to be listed. But at least getting to know you, so that you can get to also learn about the transplant team and how we function, establishing that relationship can be beneficial, and it's certainly if patients are requiring oxygen or if they are just rapidly getting worse and they're progressively getting worse, where increased oxygen needs, worsening lung function, especially over a period of 6 months, that's where listing for lung transplantation may make sense. So from at least from some of the cardiac considerations, I know that Dr. Tomic already mentioned this before. Essentially, is the reason why pulmonary hypertension is especially significant is that if the heart is, because the blood has to pump from the veins to the right side of the heart through the lungs and then back to the left side of the heart and then out to all your major organs. But if there is increased pressures in the lungs, that is going to make it difficult to go through. And as a consequence, the right side of the heart is kind of like a muscle it is a muscle, but it is really just, it's like lifting a dumbbell constantly, right? But if the weight gets heavier, instead of doing a full rep, maybe it can only do a partial rep, right? And the heart is only squeezing so hard. Now, put the patient through a surgery, hemodynamic, and when I say hemodynamically, blood pressure, heart rate, all these things, it can get complicated with there, and that's where certain things such as ECMO, as a heart-lung bypass, that is something that can be maybe necessary for that reason. And additionally, too, patients can also be at risk for high blood pressure, stiffening of the heart, and also to heart rhythm disturbances, which we want to make sure that those are that the rest of the heart's looking good. For kidneys, it's again a lot of things here, but basically is that for the patients who are certainly within the 4 years, and if they're on higher dose of steroids, scleroderma renal crisis can be a complication. And from the transplant specific situation, we do give steroids. Now, certainly we sometimes have to, for different indications and not just scleroderma, other conditions, we also modify how much steroids the patients are getting, but usually steroids are involved in it as well. Additionally, like I mentioned before, some of those medications for the immunosuppressants, those can also have long-term negative effects on the kidneys, and these are all the things that we just consider for. Now, with ACE inhibitors and everything, these are very helpful for if a patient does develop scleroderma renal crisis, but this is just some of the things that we consider, and just things to be mindful for all of you. From a GI consideration, esophageal dysmotility and reflux issues can be common. And how this is all relevant is that after transplant, if a patient has a lot of reflux and it goes then down into the lungs, that's a lot of acidity, that's a lot of inflammation, and inflammation plus lung is bad because that's giving your immune system an opportunity to recognize and therefore increase the risk of rejection. But how we essentially manage that is that there's just an understanding that depending on how severe that esophageal disease is, the patient may have to understand that there may be a period where they may need feeding access like a G tube or a GJ tube, where all the nutrition and all their medications are going directly into their stomach and minimizing what's going by mouth, just to minimize that from occurring. And usually it's temporary, but we also disclose that sometimes it's something lifelong that you have to consider. Additionally, with the surgery itself, you can also have slowing of the bowels and the stomach that can further exacerbate the issue. For vascular considerations, Raynaud's is certainly a very common feature with scleroderma, and the major thing is just being mindful where we place our arterial lines, just trying to minimize the risk of injury to the blood vessels. And for not just scleroderma patients, but really any patients, we want to have them nice and strong, what we call prehab or pre-rehabilitation and post-hab, post-physical therapy rehabilitation, and especially when there's a lot of proximal or thigh and arm and shoulder weakness that can be associated with autoimmune conditions. It's just that even that much more important that a lot of patients receive the physical therapy and have the strength they need to not only just improve or be strong enough going into surgery, but also too that they're coming out strong as possible. I'm sorry if I talked a little fast. That was a lot of slides and a lot of information, but I also understand that I want to give everyone opportunities to answer any questions you all may have. Sure, go ahead.
Like I got diagnosed with asthma. Does having asthma increase the risk of having to have like a lung transplant or lung disease with scleroderma?
No, I don't think that necessarily should be an issue. Usually for most patients who have asthma, and again, a fair question is like, well, how do you differentiate between interstitial lung disease and asthma? If I'm short of breath and I have scleroderma, how can I find out? Usually with scleroderma fibrosis, certainly on the CAT scans or imaging, you would see fibrosis and everything else like that. But at least from the asthma perspective, usually asthmatics, as long as they're carefully controlled, they don't have to progress to a degree where they need it. Certainly using various inhalers that include steroids, steroid inhalers just for the airways, but also too a class of antibodies that we call biologics. That can certainly interrupt the inflammatory signal pathway that's associated with asthma that usually it's not an issue, but no, it's usually not an issue.
In a previous talk, someone spoke about having a CAT scan every year. Who would order that for the lung?
Well, I think it's probably a collaborative effort. And in the sense, well, because one, you don't want to get too many CAT scans all the time, willy-nilly by everybody, right? But usually we try to work closely with our referring pulmonologist. And as long as we can get the images on a disc, that's all that really matters. Now, granted, I would like to think that that if a patient is seeing us for transplant evaluation, two scenarios are capable, right? Either it's an extremely early referral and we see them either once a year, or we just see them like, hey, look, we don't necessarily think that the risks of we think that the risks of transplant at this time outweigh the benefits, and so therefore maybe we'll see you in a year, and then at that point, maybe we will want to get those CAT scans done. But I think we will work collaboratively with our community physicians and kind of just deferring to them when we need it. But certainly, if there is an indication for transplant and the patient's clinically getting worse, then we certainly will want to get a repeat CAT scan at that point, just so that we know surgically if our surgeons would have any concerns with the patient. I hope that answers the question. I'm not sure if I didn't.
Not really. I'm asking, is the primary doctor responsible? Is the heart doctor responsible? Are the guys that work on lungs responsible?
So generally, when you are living with scleroderma, they'll probably follow your pulmonary function test. If they find that you have abnormality for pulmonary function test, then you will need a CAT scan. If they found disease on the CAT scan, sometimes annually CAT scan is not bad idea for the few years to establish stability. If you are progressing, or if somebody is progressing with this disease, then a CAT scan probably are needed annually. And the person who will be ordering this is probably be a rheumatologist. A rheumatologist, specialist for scleroderma.
Oh, rheumatologist.
Yeah,
They're the quarterback.
exactly.
We've got one more speaker. Jim's going to briefly share his story about the transplant, and then we'll take a quick break after that. Are you guys able to stick around a little bit after the presentation? Answer questions?
Okay, I'll try to keep it quick, and so many things from the slides reminded me of things to say. But Dr. Tomic mentioned that the lung transplant is the treatment of last resort. I was a terribly difficult patient who was very risk averse, and I was on oxygen, supplemental oxygen, for 8 years, 24/7, after I was diagnosed with interstitial lung disease caused by the scleroderma. And I was fully functional. I could travel, I could work full time, and didn't want to face, even if they told me it was 1 to 2% risk, that having the transplant could create major problems in the surgery. But finally, I was convinced by, I was a corporate restructuring lawyer, and we always advise the clients that bankruptcy is the last resort, but sometimes necessary. And they started to speak my language, and they said, we've tried all of the other medications, Cytoxan, Cellcept, rituximab, all the ones you saw listed on the earlier treatment presentation, and your lungs are still getting worse. And they said, look, Jim, it's better if we're all on the same page here. We sat down with your file, and we concluded the odds are you will live a longer life if you get this transplant than if you don't. And that's all I needed to hear. So I was now not fearful anymore of the transplant. I knew it was necessary. And all of the evaluations that you go through, that were listed in the presentation, they're no fun, that's for sure. But they prepare you so that you're psychologically ready when you need the transplant. You don't have a feeding tube implanted in the middle of your stomach unless you're pretty much ready to go. And I think in most cases, most centers now put the feeding tube in advance of your surgery, your transplant surgeries, because it's one less thing to do. And that was great because I got used to seeing it protruding from my stomach, and I got used to washing it, and so it wasn't such an adjustment post-transplant. So I had my transplant in December of 2018. I was listed and eligible to get a double. That was the original plan, the bilateral, but I didn't need to get the bilateral. Some diseases require, like I believe cystic fibrosis, you must get the bilateral. And if you have pulmonary hypertension, you must get the bilateral. I could have either one. So I got a call on December 5th about midnight saying, we got a match. It's a double. We're really happy with the match. Can you get to the hospital in the next 90 minutes? Yes, I can. Time enough to shower, get my go bag, and get to the hospital. Get another call saying, nope, the team just flew out to see the donor lungs in person. One of them appears to be a little too traumatized. But it's such a great match, we still would recommend you get the single. One of the things I learned long ago was you put your faith in your doctors. You're comfortable with them. Who am I to question that advice at that point? So I went in, got the single. I was a lucky one. My intubation, they extubated me 4 to 5 hours after my transplant was finished in the ICU. And I was only in ICU 2 days. I was discharged from the hospital in 8 days. They were forcing me to walk the next morning after the surgery because I was not I was extubated, and that was the game plan, right? They want to get you moving, walk to the doorway and walk back to the bed if you have to, but you're getting on your feet. So it was, it was such a good recovery that I was bragging about how well I was doing when we got close to New Year's. And I woke up on New Year's morning with incredible abdominal pain. I was trained by all of the physicians and the caregivers that you would almost always have at least one setback, and you have to be prepared for it psychologically. None of my setbacks, and I had 3 of them, had anything to do with the new lung. They all had to do with either, the first one was a air pocket in my stomach that took 4 weeks to get rid of. So I was in the hospital for a while. But the medications, very complicated. One of the lessons you learn is they don't have all the answers for every patient the minute you are done with surgery. With the medications, we all react differently to our meds. So I started with Cellcept as one of my main immunosuppressants. Within about 6 weeks, they thought it was causing some ulcers internally. So I switched to, I call it Imuran. It's got another name, azathioprine. And anyway, so the medications changed throughout. Another key lesson, it was on the slides. You gotta comply with the doctor's requirements for all the medications, even the water you're supposed to be drinking every day. Because I had a feeding tube, so you have to push the water into the tube every day. It's kind of laborious and it kind of isn't fun. I fell behind a little bit and I got dehydrated and I couldn't catch up. And so I actually saw Dr. Tomic when I came in for a regular appointment. He says, "You look like crap," basically. And he didn't, not his words, my words, but you don't look normal. And I got admitted. That was kind of the third time I got admitted. So I learned, militantly follow their instructions on the meds. Anyway, so I was also lucky, got my feeding tube removed. They said it would be at least 90 days. The external part clogged on the night of the 89th day. And the nurse came in to try to unclog it, and it ruptured. So I was thinking, oh my gosh, I'm going to go get a new one installed only to maybe be able to have it removed in the next couple days. That sounds crazy. And the team met real quickly and said, you're swallowing okay. We're not giving you another one. We'll remove the existing one. And another lesson I learned is I'm always more anxious about the procedures and over worried about them, and they always turn out easier than you think, and you're just working yourself up for, naturally so. It's easy to be scared, but they always turn out easier than your worries would indicate. So the woman it's an interventional radiologist who takes out your feeding tube, she was in the room with me, just the regular recovery room, and I said, "Okay, do we have to make another appointment? Do they have to wheel me out of here to another place?" She says, "No, I'll do it right here." I said, "What?" She says, "It'll take me 15 seconds unless you want to do it." And I'm like, "You don't know me well enough. I'm not looking." And basically all they do is they deflate a balloon that's filled with water that helps keep it in place. They take out all the water with a syringe, and the whole thing slides out in about 3 seconds. Anyway, so my experience, I don't think I've met a lung transplant patient who's had the lung transplant who isn't one of the happiest people I know. They are all super happy. They don't question whether they should have had it. They don't second guess it. The life changes almost immediately. And then last thing, I know Dr. Tomic was looking after me with when the statistics hit, and you might remember I mentioned I'm just past 6 years after my single lung transplant. We are not statistics. I learned it really quickly. You can't wake up every morning saying, it's been 6 years. When am I, what's going to happen tomorrow? Because those statistics are based on a host of people who have had their lung transplants going back a number of years. And the technology and the know-how in the physician world is that much better, even in the 6 years since I've had it. I didn't have many comorbidities. I was 50. How old was I now? 55 when I had my transplant. Many of those people in the statistics were much older. So I do not worry about. I literally don't live my life worried about it. there was a time in that first year when the statistics are a little scary that I worried about it, but probably not since I finished that first year. And I have not been, I've only been in the hospital in addition, other than those first setbacks in the first 4 months after my transplant, I've only been hospitalized one time, even with all my, even though I'm immunosuppressed and am more susceptible to all of the viruses. Last March, I got pneumonia and a second virus, what they called a cousin of corona, at the same time, and I was in the hospital 5-6 days. Haven't been in the hospital other than that. So this is it is the treatment of last resort, but it's a fantastic one if you have to have one. So I can field any questions too if you have. I don't want to get you too far behind your schedule, and I can talk to people out in the hallways if you want to do one-on-one. Go ahead.
It's like, I'm just so curious about wait lists again.
Yeah, well, interestingly enough, I went on the wait list and I got they call them lung offers. 2 lung offers came in within the first 4 to 5 weeks. The hospital rejected them, didn't give me an option to take them because I wasn't quite as urgent and they weren't good enough according to their analysis. And then I got, so I would say the lung I did get came, I don't know, 7, 8 weeks after I was listed. But the Chicago area, as I understand it, may have changed since I was taught, is one of the quicker areas to get available lung and matching lungs. I'll let, if anybody wants to know why, I'll let the doctors answer that. The mythology to me was always there are more available lungs in our region, partially because of gangs and drugs and things like that. That's all I got, unless there's more questions. Okay.
Thank you all. Any other questions? Just one thing I want to say, when we are talking about these complications after lung transplant, it's almost like when you are looking at medication and all possible side effects, but vast majority of the patients do very well and they have their life back.
Yeah,
Okay.
and I took mycophenolate without incident for years. So the idea that post-transplant it might have been causing an issue was very surprising to me. But the doctor said, "Look, you're taking all these other medications, and maybe all of them combined are not sitting perfectly with your particular system." And so, even our own systems change, I guess, over time, and that was that. But yeah, it was all. I'd do it again tomorrow. Hopefully, I don't have to do another one.
Exactly. Thank you, everybody. Thank you. It was a pleasure.